Imagine being wheeled into an operating room, feeling the antiseptic chill, watching surgeons prepare and instruments gleam, and then discovering later that nothing invasive was done. No incision, no implant, no physical repair. Yet somehow, weeks or months after that staged operation, a patient who had suffered relentless pain for years reports that the ache has faded, sometimes vanished altogether. This sounds like a paradox or a plot twist in a medical drama, but it is real. Sham surgery, a controlled deception, has produced genuine remission of chronic pain. The science behind that outcome is not trickery. It is a window into how belief, expectation, and the brain's chemistry can transform subjective experience into objective change. To understand this, we must shift from the operating table to the circuits and molecules of the nervous system. Pain is not simply a signal that travels in one direction from a wounded tissue to a conscious mind. It is an emergent property constructed by the brain. Sensory inputs, prior experiences, emotional context, and predictions made by neural networks all converge to create the experience we label pain. When a patient believes that a powerful intervention has taken place, a surgery meant to fix a damaged structure, the brain updates its predictions. It releases endogenous opioids and other neurotransmitters. Blood flow changes. Inflammatory responses can be downregulated. In some cases, neural activity in pain processing regions diminishes measurably on brain scans. The body, guided by expectation, essentially manufactures relief. The most striking demonstrations have come from rigorous clinical trials. In the 1990s and early 2000s, several randomized studies compared real surgical procedures to sham operations for conditions like knee osteoarthritis and chronic back pain. Patients assigned to sham surgery experienced improvements nearly indistinguishable from those who received the real procedure. In a landmark trial of arthroscopic surgery for knee osteoarthritis, patients who underwent the sham procedure, incisions were made, the theater ritual enacted, but no actual repair performed, reported as much pain relief and improved function as those who had the full operation. These outcomes forced researchers and clinicians to reconsider not only the efficacy of certain surgeries, but also the formidable role of placebo mechanisms. The neurology of this effect is increasingly well mapped. Expectation-driven analgesia recruits brain regions such as the prefrontal cortex, anterior cingulate cortex, and periaqueductal gray, hubs involved in attention, valuation, and descending pain inhibition. These centers modulate spinal cord circuits and hormone systems to suppress nociceptive signaling. Functional imaging shows that when a placebo relieves pain, the same brain systems activated by opioid drugs light up. Moreover, genetic factors influence how robustly an individual responds. Variations in neurotransmitter-related genes can predispose someone to a stronger or weaker placebo response. But belief is a double-edged sword. The nocebo effect is the sinister counterpart. Negative expectations can produce real harm. If a patient is told about possible severe side effects, their anxiety can trigger stress hormones, increase pain sensitivity, and even produce physical symptoms such as nausea or palpitations. In clinical settings, merely warning someone extensively about potential adverse effects can increase the likelihood they will experience them. Fear, it turns out, is contagious within our own physiology. These revelations have unsettling ethical implications. Sham surgeries involve deception, and deception in medicine provokes moral resistance. Yet the success of some sham-controlled trials has highlighted the need for rigorous testing of interventions whose benefits may be largely expectation-driven. It also suggests a different approach, harnessing the placebo response ethically by fostering positive expectations, building therapeutic alliances, and using honest, compassionate communication without resorting to deceit. At its core, the story of sham surgery and placebo is a story about the brain's extraordinary power to shape bodily reality. It challenges the neat boundary between mind and body, revealing that thought, belief, and context can reach deep into physiology. Whether this knowledge is used to improve clinical care or to refine informed consent, it forces us to reckon with a simple, uncanny truth. Sometimes, the most potent instruments in medicine are not scalpel or syringe, but expectation and trust.